you so much for joining me today. I really appreciate you taking the time.
You're welcome. It's great to be here today.
May is MS Awareness Month, and so I wanted to have a little chat with someone who knows as much as there is to know about multiple sclerosis as you do. The first question that I had was for you personally. What kind of started your interest in researching multiple sclerosis?
So a couple things. I think I'm a neuroscientist at heart. I've always been interested in how the brain works, and I've had some basic science training in the neurosciences, even as an undergraduate student and as a medical student as well. I spent a lot of years in the science labs and including labs at the Salk Institute. So I was always always interested in neuroscience. I think what interested me about MS early in my career, while I was training at Cornell Medical Center, were the people. I mean, so back then, if you were on an MS ward or an inpatient ward, it was mostly stroke and chronic care. And when I started, there were no medications for MS except for steroids. And so young people, or people of all ages, if they were relapsing, they would come in on the weekend for their steroids. They would get their high-dose steroids by vein, and they would get a dose. They would come in and get a dose Friday night, Saturday night, and Sunday. They'd go home Sunday night so they can go to work on Monday. And it was just a very interesting group of people to take care of, and different than most of inpatient neurology at the time. And I think that really triggered my initial interest.
Yeah, so many of the patients are quite young to have such a potentially debilitating disease as well.
Exactly. Yep. It does affect people in their 30s and 40s early.
Mm-hmm. Yeah. My father lived with multiple sclerosis, and he had it for most of my life, and he passed when he was 47, which is quite young. So
yeah, that's young.
Yeah.
Yeah. Hopefully we're doing better now. We think that still can happen, but it's rare.
Yeah, I can imagine. I can't wait to dig into some of that as well. I was wondering, for a lot of people, this will be the first time they're hearing about multiple sclerosis. So some of this might be pretty basic, especially.
That's okay.
But I was wondering if you could kind of just briefly talk about the different types or stages of MS.
Sure. I mean, there's three general types of MS. The most common is relapse-remitting MS, where people get neurologic attacks that come and go. And so you may lose vision in one eye for a couple days or a couple weeks. You might go numb below the waist. You may become numb in one arm or one leg or down the side of your body, get double vision for a few days, and that's a relapse or an attack, same thing. And it can be subtle in the beginning, and people recover in the beginning almost 100%. So for a while, it may take a while for both the person who's having these symptoms to realize it's MS as well as the doctor is taking care of them. So the most common kind is relapse-remitting MS. Over time, even as people develop a problem neurologically, we talked about double vision, maybe trouble walking or loss of vision during that attack. Over time, even as those attacks slow down or stop completely, people can still get worse. And we call that secondary progressive MS. So it's secondary, it happens second. It's secondary to relapse-remitting MS. And then people slowly get worse. So we call that secondary progressive MS. So that's the second kind. The third kind is really quite different. People slowly develop a neurologic problem over time. Typically, it's trouble with walking, and it can be subtle in the beginning. Maybe someone is really good at tennis and they notice maybe tripping over their feet, and they change to golf over time, and all of a sudden they can't walk 18 holes anymore, and they've subtly had trouble walking or running over a couple of years. They've never had an attack, but lo and behold, we examine them, we look at the MRI scan, and they have MS, and that's called primary progressive MS, or progressively worse neurologic disease from the start, primary progressive MS. So those are the three kinds: relapse-remitting, followed by secondary progressive, and separate from that, primary progressive MS.
Gotcha. And that would kind of explain why some of these symptoms sometimes look invisible.
Absolutely, especially early on. Early on, most people recover 100%. It lasts a couple of weeks. We're busy. Our foot's a little bit numb. We trip over our foot, or we're not running as well. It goes away, and we tend to forget about it. But if it lingers, or if it stays, or it happens more, if it lasts more than a couple of weeks, or if it happens frequently, it's time to go to the doctor.
So the next question that I had here kind of goes sort of into that, actually. I was wondering if you could talk about what the process is for diagnosing someone with MS. Is there an actual test that one would take, or is it sort of process of elimination or a combination maybe?
It's a combination. We don't have a perfect MS test yet. We can't take a blood test or a saliva test and say, lo and behold, you have MS. But we've really gotten quite good at diagnosing it. And MRI scans of the brain, magnetic resonance imaging, the high-powered photograph of the brain has really changed how we diagnose MS and how we follow people with MS. It's really sensitive. MS is a disease that affects the brain and spinal cord. We can do an MRI of the brain and spinal cord, and we can see the MS lesion known as an MS plaque. And again, it's interesting because MRI really just kind of came online for MS in the 80s. And we can see that plaque, that lesion, that area of destruction in the brain or spinal cord. It's bright white. And in the very early studies, they were known as U-boats, unidentified bright objects, because we saw these white lesions, these white objects on the MRI scan, but it wasn't until we correlated them with the patient and correlated them with the brain pathology that we knew, in fact, we were looking at MS plaques. So one is, if you're having symptoms that are coming and going, neurologic problems that really aren't getting better on their own or persisting, you want to contact your primary care physician, and they make contact a neurologist. First and foremost, everyone gets an MRI of the brain. They may get an MRI of the spinal cord as well. We do a complete neurologic history and neurologic exam and neurologic assessment. That gives us clues to the diagnosis that we can't see on MR. Not everything is seen on MRI scan. And then sometimes we do a spinal tap, or take a sample of spinal fluid from the lower back. The spinal fluid is made in the brain and distributes throughout the brain and lower spine, and we can take a small sample of spinal fluid. We used to do that really often when I started more than 20 years ago, but now we don't need to do that all that commonly. We can usually tell by listening to the person with MS, examining them closely, and the MRI scan, we can make a diagnosis about 90% of the time.
Wow, that's massive.
There's tricks, right? I mean, MRI is a photograph, right? It's not the brain pathology that we would see in the lab. So there are some mimics. Lyme disease can mimic MS. Other autoimmune diseases can mimic MS. So it's not foolproof, but it's pretty good and much better now than it's ever been.
Wow, that's incredible. Yeah, I can imagine that there would be a lot of things, like Parkinson's sometimes could probably look like MS, at least in terms of symptoms. So
it can. Tremor, both MS patients and Parkinson's, again, can get tremor, but again, it's usually a different age group, and the symptoms come on in a different way.
Gotcha. And so these lesions that you're talking about, do they only occur in the brain, or is it possible for that to incur in the spine? Yeah,
so the brain and spinal cord is known as the central nervous system. They also can happen in the optic nerve. So for us to be able to see, light has to be transmitted from the world to our brain, and that's through the eye. And behind the eye is an optic nerve which connects the eye to the brain. And so MS can affect the optic nerve, the brain, or the spinal cord, or any of the three.
Wow. Okay. I was kind of wondering if we have any theories about why in Canada, and even specifically Saskatchewan, our MS rates are so high compared to other parts of the world.
But we do. I mean, we don't know for sure, and we don't know the causes, but we have some clues and some associations. And so data has shown that with less sunlight, there's less activation of vitamin D. So the vitamin D in our body has to be activated by sunlight for our body to use it. And so there's pretty good data to say the further you are away from the equator, you're higher risk of MS. Okay? That might be related to less sunlight, and it's related to lower levels of activated vitamin D3. It's not the whole story. It's not causation, because again, there's other reasons why MS might be more common in more temperate parts of the world. So there's almost none at the equator, and the further you get from the equator, the more MS you get. So that could be a sun issue, but there's probably a genetic component as well, because historically people immigrated in groups around the world, right? And they tend to stay together. before transportation was so easy. And so there's an environmental component. One of them is sunlight and vitamin D3. There's a genetic component as well. And there's a lot of other components that we don't understand yet. So that's part of it. Now, why it's so high in Saskatchewan, we don't know yet, but we hope to figure that out while I'm here.
That's awesome. So when you say activated vitamin D, I can't run out to Walmart and pick up some vitamin D capsules, and that's not going to potentially curb my risk of MS.
Well, it can reduce your risk. It can't. It won't. As far as we know, it doesn't treat MS, okay. But it does look like it can reduce your risk. And so you would get vitamin D. You would take some vitamin D3. Get the dose from your doctor, but we usually recommend around 2,000 units. It could be a little bit more depending on your blood level. And then most people are taking some vitamin D3, and then the body activates it through sunlight.
Wow. Okay. Well, that's pretty cool too.
Yeah. It's not I want to be clear, it's not a treatment.
Yes.
But it may reduce your risk of getting it.
And it's probably not a terrible thing to be taking, especially in the winter months anyway.
Right. And you just have to be concerned about the dose. You don't want to take too much vitamin D3. You can get toxic from it. And it's also reasonable to get a blood level and see what your blood level is and see if the vitamins you're taking are improving that level.
Right. Yeah, of course. That makes sense.
Yep.
Yeah. So this is the part that I was really excited to ask you about. I used to work at the MS Society in chapter in Brandon years ago when I was going to university. So I'm pretty out on the loop on current research and new treatments and things like that. So I was wondering if there's anything new and exciting that you could kind of tell us what's going on in that world right now.
Right, so we can talk a little bit about treatments and then some about the research here and research in general. First of all, I do want to say at the outset, there's a lot of hope for people for MS, and it's not false hope, it's real hope. There's really been a lot of great research done in the last 20 or 25 years. And so when I started in this field in the early 90s, there was only one medication approved for MS, beta interferon 1B. And then there were others, and over time, and those medicines worked, but they were hard to take. There are now, I think, as many as 15 or 18 different medications on the market for all different kinds of MS, for all different people with all different lifestyles. And we can really sit down and choose one medicine that may fit a person. And also, someone's not married to a single medication. That is, we can try it for a while. If it doesn't work, or if the person with MS does not like the side effects, we can switch. And that's really well supported in our province as well. Okay. Some of the newer medications that are interesting, one is siponimod. And what's interesting about that is we talked about relapse and remitting MS.
Yep.
Almost all the drugs invented were invented for people with relapse and remitting MS.
Really?
And they have a lot of choices. Secondary progressive MS, the only drug that's now approved for, again, secondary progressive MS, that MS that lingers after the relapsing phase. Siponimod is the first medication approved for secondary progressive MS, and that was just approved this year in Canada, and it's available here in Saskatchewan. Ocrevus is another newer medication that treats relapse and remitting MS, but it's also the first one to show that it may work for some people with primary progressive MS. So even in the last couple of years, this has changed. So again, when MS research started, we only had a handful of medications that were self-injectable, and since then, oral medications have been invented, and now medications that really are high efficacy or work really well have been invented, all for relapse and remitting MS patients. But now there are options for secondary and primary progressive MS as well. So that's new, and that's a result of years and years of very hard research.
Yeah, absolutely. And so these medications, is it realistic for MS patients to be on these long term? Can they be on this kind of, if it's working for them, is that a lifelong medication that is safe for them to be taking?
For both. I mean, some of the medications are lifelong commitments, just like it is for any other chronic disease like diabetes or high blood pressure. Other medications, remember, MS is autoimmune, and so the immune response that is there to protect us, for some reason, goes into the brain and spinal cord and
Right.
begins to attack the brain and spinal cord. So almost all the medications suppress the immune response. And so some of them suppress the immune response so strongly that people only need to take them for 2 or 3 years. And then
Wow.
you follow them, and they may not need another medication for years of their life. So really, it depends on the medication, depends on the person. But a lot of them are lifelong commitments.
That's incredible. Wow.
Yeah.
I did not, like I said, I'm pretty out of the loop on these things now, but that's the last that I kind of remember chatting about when I worked at the MS Society was the new thing at the time was, I believe it was Dr. Zamboni.
Uh-huh.
Found that you could put stents in the blood?
Right.
I think. I hope I'm not misspeaking.
No, that's right. And those studies were looked at carefully, and finally controlled studies were done, and it found that procedure, when studied carefully, did not work. And a lot of my patients tried it.
Yep.
We can walk through that one day. That's a whole nother story. I'm happy to walk people through the process and the thinking behind that. And a lot of my patients have tried it, and I think some felt that they felt better for a short period of time, but that it probably was not long lasting.
Right. That's exactly what I remember reading about it. So that's
right.
Nice to hear. I wasn't sure if what was being focused on in research was more on procedures like that, or maybe even completely different, but procedures or medications. So it sounds
right.
like
So it's really medications. We're trying to figure out how the immune system in people with MS is different than those without MS, and how to dampen that immune response so it's not as aggressive.
right.
And so it's no longer attacking the brain and spinal cord as aggressively. And by dampening that, we can slow the disease. And the medications show that now. The long-term studies of these medications show that people are relapsing less frequently, are being able to walk for longer periods of time, and live full lives for longer periods of time.
That's amazing.
Again, there's a lot of hope.
That's so great. That's exactly what you want to hear. I mean, not to
Yep.
put you on the spot, but I'm just like,
That's okay.
good news on me.
So let me spend a few minutes talking about our research here.
Yeah, please do.
If that's okay.
Yeah,
Okay.
absolutely.
So we made a discovery here in Saskatchewan, and that people in the nerve cells from people with MS contain something called stress granules. So I want to walk people through that. Okay, so the discovery, again, which we discovered here, is that we took brain samples from people who had died from MS, and we looked under the microscope with special stains, and we found inside their nerve cells there were stress granules. Okay, stress granules, in actually small amounts for a short period of time, are good things. They actually protect a nerve cell from stress, and not only physiologic stress like we're all feeling right now, staying at home. But other kinds of stress, like the stress of being attacked by your immune system the whole time. And in short term, what happens is the nerve cell senses the stress, and what it does is it takes pieces of the cell, and actually in the cell forms a granule. You can see it, kind of like a grain of sand. And it takes little pieces from different parts of the cell, and it forms the stress granule, and it protects those components of the cell, and it kind of makes the cell go to sleep for a while. And then the stress goes away, and that stress granule dissolves, and all its little pieces go to the right part of the cell. The cell wakes up in the cell, and its machinery goes back to normal.
Wow. So
That's
the
under the
granule is different than what you would see under an MRI with the lesions in the
right. We can't see stress granules by MRI, at least not yet. Maybe there's a day we can find a marker for one. Now, in MS, what happens, we think that there are too many stress granules, and they stay too long. And so what happens is, like anything else, a little bit of stress is well tolerated. Some people think a little bit of stress is a good thing, but persistent, everyday stress, constantly being under this barrage of this attack by the immune system, the stress granules stay too long. And by staying too long, those components of the cell can't do their job, and the cell slowly starts to die.
Right.
They may stay too long, and there may be too many of them. And so what we're looking at, so now we found them in brains from MS patient. We found it in one patient. That was our original discovery in 2018. We've now replicated it in 6 or 7 patients. That paper's coming out in the next couple of weeks. And we can also develop stress granules in the lab. So either using nerve cells that we can grow in a petri dish, or looking at animals in a disease or that mimics MS, we can actually stimulate and actually cause the stress granules to form. And now that we can see them and get them to form, we can design medicines to either reverse them or dissolve them so that the cell lives longer. And that's the work we're doing here now. And there are already drugs invented. They're not on the market yet, but there are already medications from the pharmaceutical industry that we're testing in the lab to see if we can change stress granule biology to take them from being bad to going back to being good. Right. And that's all been done here at the University of Saskatchewan.
That's amazing.
Yeah, very good. Very, very excited about it.
Yeah. So are you hoping that that'll help you find a cure for MS and like trying to make those granules go away? Or is it more so a clue into what actually causes MS? Or maybe it's both.
I think, I'm not sure stress granules will teach us about the cause. That is what initiates MS. I'm not sure it's there yet, but our hope is, we've talked about progressive MS, both secondary progressive and primary progressive MS. So in a lot of patients, we've quieted down the relapses, so they're not getting those acute attacks, but years later, they slowly get worse. That term is progression, and when we look in the brain of people with MS, while they're progressing, it looks like there's nerve cell damage. And so our hope is that we can protect the nerve cell so people no longer progress or get worse. So in our vision, people would be taking a medication that will stop the relapses like they are now, and then we would invent a second medication to prevent the progression, to preserve nerve cell function or to preserve the nerves working normally so people can even live fuller lives longer and hopefully forever. So we're looking at the progressive part, and we're trying to nip that in the bud.
That's pretty exciting. That's a huge, man, I'm proud to be from Saskatchewan right now too. Amazing.
It's an exciting time. We're getting, students are interested in rotating in the lab. Other people are looking for jobs in the province from other parts of the country to join our team. So it's a very exciting time.
Wow, that's amazing. I guess just to kind of close things off,
yeah.
A person thinks that they may be experiencing symptoms of multiple sclerosis. What is the first thing they should do?
So I think the first thing they do here in Saskatchewan and Canada is contact their primary care doctor. They're the gatekeeper, and you want to go and see that person as quickly as you can and describe your symptoms and see if they fit someone that sounds like MS. The second step is to be referred to a neurologist. Any neurologist can see you. We are MS specialists here in Saskatoon at Saskatoon City Hospital. We're happy to see new patients. So get referred to a neurologist, and we're happy to see you here. We'll see you as quickly as we can, and either just after our visit or even on the way in or before the visit, we'll get an MRI scan of usually the brain and the upper spinal cord, which we can show you. And again, that combination of what people describe their symptoms are, the neurologic exam we do at the bedside, and the MRI scan, and we're happy to show the MRI scans to everybody. From those three things, we can usually diagnose about 90% of the people. So those are the steps people should take.
That's awesome. Well, I hope everyone learned a little bit. I know that I definitely did. So I really, truly appreciate you taking the time. Thanks for kind of explaining it so that everyone can kind of understand and hopefully learn a little bit more about the condition.
No, it's my pleasure. I'm happy to do it anytime.